Hi everyone, thank you very much for joining us today for our webinar for March. In the spirit of reconciliation, we acknowledge the traditional custodians of country throughout Australia and their connections to land, sea and community. We pay our respects to the elders past and present and extend that respect to all Aboriginal and Torres Strait Islanders. My name is Nell Thompson. I'm the Secretary of the Australian Institute of Animal Management and I'll be hosting the webinar for you today. I've been on the AIM committee since 2013 and I'm also the coordinator of the National Getting to Zero program. The Australian Institute of Animal Management is the national peak body representing local government animal management officers. The AIM committee consists of a wide range of professionals engaged in various aspects of animal management. AIM seeks to support those engaged in the business of animal management and the function itself by providing training and information, opportunities for networking and collaboration, and by encouraging the use of best practice, policy and practices. AIM understands the significant pressures placed upon local government and the not-for-profit rescue and rehoming service providers when working in the companion animal management space. We welcome new members and people can join via our website at www.aim.org.au. So to the agenda for today. Once I hand over to our presenters, there'll be around 50 minutes of presentation and then around 10 minutes of question time once the presentation is concluded. The recording of this webinar will be accessible via our website to all our members to watch at any time. We're going to ask that people mute themselves during the presentation unless our presenters ask otherwise. And if you have any questions, you can start putting them in the Q&A section and we'll get through as many as we can at the end of the session. If you have very quick questions that relate to your understanding of the content, put your hand up. You'll see down the bottom of the screen, there's a raise hand icon and we'll try to get to them during the presentation. If you have more questions or we don't get to yours during the question time, you can send us a message to our Facebook page and we'll get to it that way. As always, please excuse any working from home background noises that may filter through. We're very grateful to have Drs. Margulies and Brennan here with us today to talk about their research into patients hospitalised by dog bites. Dr. Margulies is an infectious disease epidemiologist with qualifications in both human and veterinary public health. He leads the Spatial Epidemiology Laboratory and One Health Medical Geography Group within the University of Queensland. His primary research focuses on the application and development of spatial risk assessment methods to provide epidemiological evidence for more rational implementation of strategies for the control of infectious diseases of animals and humans. His lab uses contemporary epidemiological tools, including spatial modelling and more recently, molecular epidemiology to answer questions regarding the implementation of zoonotic disease control in Australia and developing countries. Dr. Brennan is currently working at the Princess Alexandra Hospital as an emergency medicine registrar. He's interested in bridging the gap between clinical medicine and human public health. His primary research focuses on emergency department presentations secondary to animal injuries and the epidemiological factors that influence these presentations. We are really excited to have these fellows here with us today and really appreciate the time that they've taken to speak to our sector directly. So over to you, Ricardo and Bradley.
Thank you very much, Nell, firstly for the invitation, and thank you to the Australian Institute of Animal Management members to attend this webinar. We're very excited to impart on you some of the results of the investigations we've been conducting in the Brisbane Metro South region. As Mel mentioned, I'm an infectious disease epidemiologist. I'm a veterinarian, so most of my research is around infectious diseases. But dog bites, they are an important vehicle of a number of infections we've been working on the past few years, particularly in China with regards to rabies control. So I basically enticed Brad to see if we could do something in Australia, not on the rabies context, which we are free of, but on the dog bite aspect, which is gives us some insights on other dimensions of the problem. Now, the talk is sort of split in a couple of sections. The first section, Brad will be going through the emergency department sort of perspectives on the treatment of these conditions. And then I'll go in a little bit more detail into our findings of the ED presentations for dog bites in the Brisbane Metro South. This paper has already been published, is available online, and perhaps Nell can later on share with everyone that link. It's an open source sort of journal, so everyone can have access to the more detailed findings. So dog bites are in part a very important public health burden in a number of populations, not just in developing countries, but also in developed countries. They're important vehicles for trauma, not just infectious diseases, but key infectious diseases that involve the control or the mitigation of dog bites in developing countries is rabies. So rabies is at the very top of the priority list to curb the incidence of these events of dog bite attacks. There are other infections associated with bites, particularly capnocytophaga infections, which is a commensal. It's always present in the mouth of dogs, and in some occasions, particularly in immunocompromised individuals, can cause gangrenous sort of lesions, which are very difficult to treat. The slide you're seeing, the picture on the right-hand side is how those bacteria look like on the microscope. There's a number of other injuries that can be a result of a dog bite attack. Open wounds are obviously the primary result, but then you have secondary impacts on the health of the individuals that are affected by these attacks. And Brad will go into a little bit more detail into the management of these conditions.
Yeah, so I guess from an ED point of view, things we sort of get concerned about for dog bite presentations. So during our initial assessments, I guess the two things we're mainly looking at is the patient themselves and their background, as well as factors regarding the bite themselves. I guess one of the things we learned from doing the study is that doctors are quite poor in terms of documenting their more epidemiological factors for dog bite presentations, and we focus quite heavily on the patient medical history and the bite characteristics itself. So I guess in terms of things that we look at initially, we sort of give a bit of background on patient history, basically trying to identify to ourselves which patients will be the high risks for complications, and then therefore trying to prevent those complications from happening. So we're looking for trying to determine whether those patients are immunocompromised in any way, other medical comorbidities which may impact on their care. So predominantly whether they're on any medications which might impair wound healing, or place them at risk of infection down the line. We also look at the immunization status, the main one being sort of tetanus. Rabies is more for those patients who are return travellers from overseas areas, so whether they got bitten by a dog in Bali, for example, then come back to Australia. And in terms of the actual wound itself, really we're trying to determine what are the risks of that wound in terms of getting infected later on, or whether it's already infected, and then potential complications from the wound in terms of nerve, tendon, or joint injury regarding to that wound injury. So particularly the main difference is a big difference between paediatric presentations and adult presentations. So often we find that paediatric presentations are a lot more complicated to manage, partly due to the types of bites that paediatric patients sustain. So we know from the literature that paediatric patients are most commonly bitten on the head and face, as well as commonly bitten on the hand. And I guess these areas are quite complex areas to manage. So the face issues being sort of cosmetic appearances and sort of often needing multiple teams to be involved to manage those bites, and then bites of the hand being complex in terms of there's lots of tendons and nerves and muscles there which can be injured. So often they're quite complex to manage. And so often we find these paediatric presentations take a significant time to assess as well as sort out in the ED. The other thing we're assessing as well, infection is whether infections are already there or not. And that influences our antibiotic choice as well. So we know that dog bite wounds are sort of polymicrobial, and therefore that guides our antibiotics to be sort of quite broad spectrum. Next slide, Ricardo. Investigation-wise, often investigations aren't routinely required for most bite wounds. If we do investigations, it's predominantly just trying to look for complications, so any sort of retaining foreign bodies there or collections, abscesses, and we don't commonly routinely swab bites unless they're already infected. In terms of our ED management, our initial management is mostly essentially it's first aid. It's trying to wash out the wound as much as we can, get rid of all sort of foreign material and debris out of the wound. Wound closure is quite a controversial area in terms of whether we close these wounds immediately, so primary closure versus secondary closure at a later date. In most wounds, we usually elect to close as primary closure in ED unless they're in a high-risk area or already infected. The other sort of controversial area is antibiotic use as well. So there's differing guidelines depending on where you work about which antibiotics we use and also which patients we give antibiotics for. The general consensus, though, seems to be that most dog bite wounds will receive prophylactic antibiotics, although the evidence for that is not great. And usually the antibiotics we use are quite broad spectrum antibiotics, purely based on the fact that the wounds are sort of polymicrobial in nature. The other issue we find is in terms of managing pediatric patients in particular, is they are quite significant time consuming and resource intensive in ED. So often pediatric patients will require some sort of sedation if it's a significant injury to actually formally assess the wound and wash the wound out and to close the wound as well. Often if we get a pediatric patient, they'll be in ED for several hours at least while we try and sort it out, unless it's a simple scratch. Most peds patients will be in ED for a while. And so ideally, we want to try and prevent these injuries from happening and reduce the load on ED so that we can direct our resources elsewhere. Next slide, Ricardo. So I guess, to talk about some of the challenges. So as mentioned previously, pediatric patients are particularly challenging for us to manage in terms of assessing the wound and managing the wound. Often require sedation to explore the wound and assess it, and then sedation again to close the wound. If they're in any sort of high-risk areas, like face or hand, they also often require multiple medical teams to assess. So like plastics teams, max facs and orthopedic teams, depending on where the injury is located. And then all this sort of puts pressure on the ED as well, in terms of we know our EDs are already pretty full and stretched, and having these patients in ED for a long time isn't good for the patient and not good for resource allocation as well. So anything we can do to identify where these bites are occurring and why they're happening does filter down and help ED out as well. So I guess that's why I sort of got into this research originally. I guess the other challenge as well is antibiotics controversial, and if you go to the next slide, Ricardo, as you can see, depending on where you work, the antibiotics vary, and they vary depending on who you give antibiotics to as well. So the Children's Health Queensland guidelines are the ones that we use here in Brisbane, and they sort of recommend antibiotics for all human bites and high-risk injuries, so hand and face, for example. But you can see that they differ from the Perth guidelines, which recommend antibiotics for all bites, and the Australian therapeutic guidelines as well, which stages for high risk bites. So they're all quite variable. No one really knows what the correct answer is. But I guess we sort of fall back to a default in ED that everyone gets antibiotics, and they get quite broad spectrum antibiotics, which have their own complications. So still an evolving area at the moment. So there's sort of some of the things that we sort of look at from an ED point of view, and ideally we want to try and reduce these presentations to ED and have a bit more of an understanding about who these patients are, they're getting bitten, and why they're getting bitten. Yeah.
Yeah, thank you, Brad. The question here we're trying to address is really how can we minimize these challenges that the ED department is observing on a routinely basis by looking at potential strategies that could be applied within the community to reduce the number of cases going through the doors. There's a lot of discussion around the risk factors for bites. The first point of discussion is always the breed, what we call the breed hazard. And evidence from the United States is showing that most attacks are within these dog breeds that are traditionally linked to the serious, severe attacks generally. They tend to be generally sexually intact dogs. The reason why that some of countries opt to desexing as a way of reducing the tendency for aggressive behavior, which has not really been well demonstrated categorically that it is a way on its own to reduce the incidence of dog bites. Male dogs also another demographic risk factor that has been popping up in a number of studies. And that is something that has been quite consistent across different countries. And also the breed discussion has led to a number of jurisdictions to adopt legislation to restrict the presence of these breeds in the population. Queensland is not is also, well, it's not an exception. We have some restrictions moving across the board for some breeds, and I'll talk about that in a moment. And this legislation is specific to particular breeds, which is quite challenging in terms of clearly have a neat categorization of an animal. There's a lot of crosses happening, and so there must be some genetic predisposition if those crosses are in the population, which they do not fit really neatly within these individual breeds. So most attacks can definitely be avoided, and that's what most studies have been showing in terms of looking at dog-mediated rabies. And most attacks can be avoided by proper supervision by adults, proper education of dog owners in terms of how they handle the animals, and also an understanding of the fact that dogs, like us, like human beings, have different behaviors. They do have fears, they do have moments during their lives where things are not going that well, and so understanding that context as well helps on the reduction. Some of the forms of aggression can, as it says there in a bullet point, may require specialist behavioral therapy, and now veterinary schools across the world are really looking into training the incoming veterinarians in this sort of domain. And also there's a specialization, boards of specialization looking at animal behavior as one of their domains of the specialization. So, but these are really emerging topics. But again, the mediating factors on the breed hazard play a very important role at understanding what's going on locally. In Australia, the most current evidence shows that dog bites are on the rise. And this is a study published in the Australian New Zealand Journal of Public Health in 2017, demonstrating that overall the annual rate is close to 13 per 100,000. This is almost threefold the rate, say, of a condition like Q fever. So it is imparting a significant public health burden in the hospital service. Again, from this study, the age groups that seem to be mostly affected are the pediatric subgroup, aged 0 to 9, with rates that can go up to 25 per 100,000. That's quite significant, looking at a number of conditions as a comparator. So on average, these bites, they are morbid. So that means they cause injury, but not death. So most of the cases are treated, and only very few lethalities as a result of these dog bites. But that doesn't mean it's not a significant problem, as Brad highlighted, in terms of the management in the ED department, and some of them require admission. The hospitalization that has been mined several times around in Australia, the different studies available in the literature from South Australia, for example, showing again the pediatric sort of burden as the key sort of demographic that are affected in that state. And they've looked at as well and identified this gender hazard and another breed hazard with German Shepherds. The data they had available was they were able to tease out the risk factors associated with these breed hazards, and they looked at the behaviors of owners towards the dog that resulted on the bite, and it says the majority of the incidents, they do tend to occur in the dog's territory within the household, usually imparted by dogs that are known by the person that has the injury, and they can have very long-term effects, mainly as part of the trauma associated with the event, particularly if it happens in a pediatric case. So it is really important to look at the incidence and health education very early on, so that these events in childhood do not happen. The studies in South Australia, also in Victoria, showing similar patterns. This is a publication in 2007. They looked at all the different bites and attacks from animals presented to the ED department. Interesting there, humans come second in the bites, in the sort of the rank of bites, dogs at the very top. But again, the injuries, one important insight from this study is that most injuries seem to happen during the holiday season and during the period where people are usually at home, relaxed in the household, where presumably more time is spent with the animals. And the severity of patients is something again that pops up with about 12% of the patients looked into this database from 1998 to 2004, requiring hospitalization and hospital admission. So these are severe cases that end up several days in hospital. The results from studies in Queensland before our study were also quite interesting. The breed hazard again popping up within those hospitalization databases, and also correlated very well with the findings of the studies in Victoria, looking at most incidences happening during the weekends, and also occurring during the afternoon, presumably when people are back home and take the dogs for a walk. There's also allusion to the fact that individuals, when taking dogs to dog parks, they have an increased exposure to attacks within those dog parks. This is a study that was done in the 1990s, and then was followed up shortly after with similar findings in 1991. So both these studies were underpinned really the legislation that we currently have in Queensland in terms of animal management, which some of you already may be aware of. But for those that aren't, we've got the Queensland Government Animal Management Act that looks at the definition, classification of regulated dogs. These are animals that can be classified in 2 tiers, the dangerous dog declaration, and these are usually animals that have inflicted serious attacks on persons or animals. So not just the victim being an individual, a human, but also on animals. Also, the dangerous dog declaration can be posted on an animal that has acted to cause fear on an individual or an animal, or has a behavior that is a violent behavior towards a person or an animal. These dangerous dog declarations can also be placed on an animal by an authorized person that forms an opinion in relation to the behavior, and also an animal that moves from one jurisdiction where it has been declared a dangerous dog, then the Queensland government also ratifies that declaration from another local government area and imposes the same classification. So the difference between dangerous and menacing dogs is not linked to the breed. And I think that's a very important point to make. It's really around the event, an attack that has happened, and also the behavior associated with the animal in regards to the presence of a human being and an animal. The difference between dangerous and menacing dogs is very nuanced. And the major difference there is on the severity of the attack. So in less severe attacks, dogs are not placed on the dangerous dog declaration, but rather on the menacing dog declaration. So there's a number of repercussions which are quite significant for the animals themselves, but also for the owners. One thing is that these animals need to be registered. They need to be desexed, kept enclosed. The difference between dangerous declaration and menacing dogs is that the dangerous dog declaration animals, they can't leave the enclosure, they can't leave the household, whereas menacing dogs can still leave and be accompanied. The enclosure needs to have a sign with showing the fact that there is an animal with that sort of declaration present, and they need to have a special collar or a tag to be clearly identified. So this is what the Act is mentioning. So again, from a public health perspective, looking at the dog attacks and understanding the geographical distribution of these cases can give us a hint of areas where we could do something else, interventions in the population level to reduce these animals moving into these declarations. Now, in Queensland, we also have the Council Animals Law Act law, which is about a list of dog breeds that are prohibited in Brisbane. But again, many challenges for clearly define these animals, particularly when you've got crosses. You can use the Australian Kennel Club classification, but even for trained veterinarians, it can be quite challenging when determining whether there is a cross present with a particular breed. So all of this background to let you know that we can do something to reduce the attacks that are happening in humans, but also to reduce the likelihood that animals move into these categories. One of those tools is to understand where the events are happening, so we can target interventions. So spatial epidemiology is sort of an approach, an epidemiological approach to disease. In this case, dog bites, that can give us an understanding of particular hotspots of dog attacks and dog bites, and also the size of the problem and sort of profile the areas that are at a greater risk of the dog bite incidents. The ultimate goal, as it says there, is really targeting disease control interventions. And then I'll give you some examples on how we've been doing this in collaboration with our Chinese counterparts in the hotspots in China. Now, spatial epi tools are very sort of prevalent these days, and COVID again gives us a lot of insights into how these tools have been useful to the common citizen to understand where the situation is happening and how things are evolving. But in the context of animal attacks, we've got a system of online system of citizen science where individuals that have been attacked by magpies can go in and log the event. So again, this is not a database that is present in a hospital record. Is really provided by the community and individuals that have been sort of affected by a magpie attack, and they go into this system and log and record the attack and the level of severity as well. So if you've been attacked by a magpie, but that attack was not very severe, then you put a yellow. If it's been more severe, then the pin will fall and that pin will be red. So we're hoping to do something similar with the dog bite information that we have available, but given the rarity and the confidentiality around these events, our plans are not to place a pin, but rather to understand incidence on an area level, at the local government area level. And I'll show you some work on that in a moment. So there's a number of risk factors associated with the dog bite events that we use to understand the spatial epidemiological characteristics of the populations at risk. So the first one is dog bites occur where people and animals are living. So we need information about the population distribution. For the human population is generally easy to obtain. That information is available from censuses. The challenge is the denominator for the dog population, which is quite challenging to obtain. And usually it's very fragmented and different jurisdictions capture it in different ways. The other sort of information we need to understand in terms of risk factors is the distribution of socio-demographic or socioeconomic factors that can affect the incidence of these events, particularly social economic status of the populations, the level of health education, and the level of health access as well. Not all dog bites are reported to the ED department. Only the very severe ones will end up being reported. And so what we are really capturing is really the very tip of the iceberg. So this health access factor is very important to factor in the modeling so we can adjust for potential biases in the results of an analysis that looks at hotspots of dog bites. The other level of information we need to do these studies is the distribution of control interventions, the neuter status, so what proportion of animals within the population are neutered, because we know that can influence the aggressive behavior in a population level. Health education of individuals, and in the case of rabies and other diseases transmitted by bites, the vaccination coverage, which can determine the incidence of bites that result in infectious outcome. Other important factors, and these ones have been explored previously in other studies in relation to dog bites, is landscape variation, particularly the physical environment, the access of dogs to the outside, the presence of parks, for example, and climate indicators. There's been some evidence that temperature can have a significant effect on the behavior of dogs, particularly hot temperatures. And I'll show you some evidence on that later on. So we're trying to put together a database of risk factors that can explain our dog bite incidence in the Brisbane Metro South region. And that's what we tried to do in this study. So we've obtained data covering the period from July 2013 to June 2017 of about 1,500 dog bite cases from the 4 main hospitals in the Brisbane Metro South Health District. And we had 3 aims. The first one is to look at these temporal and geographical hotspots of dog bites in Brisbane. Second is which risk factors are associated with those hotspots, and finally sort of develop a spatial decision support system that combines admissions and citizen science. So we've completed the first 2, and we are now going into the third aim and hoping that to collaborate with local government areas and the councils affected that are part of this geography to see if we can develop this decision support system. Now, looking at the whole database available to us, two things were quite striking. The first one is that there is significant seasonality in the events, and we see this this peak in the November-January number of dog bite incidences in the Brisbane Metro North region. That's quite stark. The number of factors may be involved in the seasonality we are observing. But the other thing is that there is an increasing trend in the number of head injuries. So the head injuries correspond to the red line. And we see that there is an increasing trend. We don't see a very clear trend in terms of the number of representations and the number of pediatric patients. They tend to be quite constant across the time scale we've been able to investigate, but the number of head injuries has indeed increased over time. So we wanted to really understand where these events were happening, particularly for these three outcomes. So the number of pediatric cases, looking at the probability in terms of the geographies affected for the number of pediatric patients. We wanted to also know which areas where did we have, patients coming with more head injuries, and also which areas we had patients representing more often. So there's a couple of things happening here. This is individuals that, due to the severity of the wound, have came back for further treatment, or they have been rebitten by another animal, or presumably the same animal. So looking at the different hospitals, we can see two distinct patterns in terms of the demographics that are captured by the four hospitals. So the Logan Hospital, which is south of Brisbane, tends to have sort of a curve that is a descending curve with overrepresentation of pediatric cases, and also similar to the Redlands Hospital incidents. So here in the Redlands is on the eastern side of Brisbane. And in these two regions, we see that pediatric cases are indeed overrepresented in the databases. This is not happening in the QE2 hospital, which is sort of southeast Brisbane, and also the PA hospital, which is sort of southwest Brisbane. The pediatric cases are not overrepresented anymore here. The bulk of the cases are within the 20s to the 50s, which may represent the underlying demographics of the population, younger people and families living in Logan and the Redlands, as opposed to more mature families without children. So these things we needed to account for, is that depending on where you are, the demographics that hospitals will end up receiving will be quite distinct. And so the pediatric cases tend to be admitted or be presented to hospitals in the Logan and Redlands areas. When we look at the general distribution, and this is overall number of cases in the landscape, we're not adjusting by the total population at risk here. We can see some clustering already. The little blue dots represent the location of the hospitals, and the areas in red and green represent the gradient in the number of cases. So we see significant sex differences, again, males, and consistent with the evidence, males being more affected than females. And in terms of the body region, we see that males tend to be bitten more often in the legs and arms, compared to females, and no significant differences across the different other body regions in terms of sexes. In terms of ages, we see a difference between the very young groups. The children tend to be bitten, as Brad mentioned, and again corroborated by the Brisbane Metro South data, in the head, face, and neck. A very high representation there. And then the other subgroups in the hands and arms. When you look at the adults, and there's a very interesting study in Brisbane done in postmen, in postal delivery offices, and these patterns we're seeing in the Brisbane area for the 2013-17 really resemble the findings that were done in this particular subpopulation, with post office officer being bitten more often in the legs and foot as part of their normal occupation. which was really interesting to see this study capturing this particular population at risk. Now, our studies, as I mentioned, we've broken up the 3 outcomes into 3 distinct sort of outcomes. The first one is looking at the probability of pediatric patients, and the map on the left-hand side is showing the observed incidence. Now, here is adjusted by the total population at risk. The Redlands area again being overrepresented there, also the Logan region as well. And the important risk factors that remain significant in the multivariable analysis. So I would just like to highlight that for pediatric patients, the location of the incidence tends to happen in the own residence, and it's a 3-fold effect compared to outdoors. So children tend to be bitten within the residence. In terms of locations, and this is a factor that remains significant in the multivariable analysis. Again, the head and face and neck, quite important as a site of interest in this particular subgroup, demographic group. Interestingly, we found that children tend to be bitten more often by larger breeds. So we see this is a negative effect here, a small effect or an inverse effect, less than 1 for the medium and small breeds. So that means that the larger breeds tend to affect more the pediatric population compared to the small and medium breeds. Another factor that was significant in your variable analysis is the behavior. So what were individuals doing in the moment of the attack? And most of the pediatric cases were playing with the animal at the moment of the attack. So that factor did not move into the multivariable model. And so other factors may be playing a role, and we then adjusted for a number of environmental factors like the social economic status of the population, the underlying population. And we've been able to predict the prevalence across, or the probability of pediatric patients across the landscape over here. So our data are just for Metro North, but using a spatial model, we can, given the certain conditions that we impose on the model, particularly the social economic status and the population characteristics, we have been able to predict prevalence across the rest of the landscape. Very clearly, the Logan region, where prevalence is predicted to be highest, as well as the regions in the Redlands. We did the same with head injuries. These again tend to occur in very young age groups, particularly the under 16s. And also an important finding of this study is that head injuries tend to be inflicted by small breeds. When you compare the effect size for dog size, small breeds is almost 6-fold higher compared to larger breeds. Where these cases occurring? Well, pretty much they are occurring in the inland areas. The head injuries are more localized to locations away from the main urbanized center of Brisbane. They tend to occur in more sort of peri-urban rural areas of our landscape. The representations, well, nothing really stood out completely. A couple of things to note is that these tend to occur, well, marginally. Again, it's a marginal effect in the age group 40 to 64, and also inflicted by larger breeds. So medium dogs, they are at very low risk compared to larger breeds. It's possible that these individuals of that age group between 40 and 64 are being inflicted with more severe injuries and then representing to the hospital for further treatment, or being rebitten as part of their normal sort of activities. The map is very similar to sort of moving out. So the pediatric tend to be concentrated within the city. The head injuries a little bit further out, and then these representations tend to come from individuals that are usually located away from the main urbanized center of Brisbane. There are other factors that we are also exploring to understand the why we see more cases during that November to January window. It could be associated with holidays, but it could also be associated with ambient temperature during that time, which is quite warm in Brisbane and in most of Australia. So we have some data from Beijing where there's a clear indication that temperature does have an effect on the incidence of dog bites in China. So we are exploring the effect of ambient temperature as a confounder of the holiday effect that we are seeing in the Brisbane Metro South. Now, what can we do with all of this information, right? So this is some insight very briefly. I think we've got just a couple of minutes of what we've been doing with our Chinese counterparts in the context of rabies and how these spatial epidemiological tools have been used to guide interventions more locally. So we've been working with the China CDC, the Centers of Disease Control, on the human notification there. This is not hospitalizations, these are notified cases of rabies. And over here, you see that there's been a stark decline in the number of cases from 2007 onwards, particularly because of their draconian sort of program in the dog depopulation in communities that are mostly affected by rabies. So you see a sharp decline as a result of those, and coupled with the vaccination as well. But this sharp decline you see here in 2 years after the program started is mainly driven by the dog depopulation. And then when vaccination kicked in more systematically in the rest of the country. So we've been doing some work on looking at the size of the clusters and how far should we be vaccinating when we've got local cases of rabies. These studies have shown that most cases are concentrated within small clusters of 10 kilometers of a case. So every time there's a human case, now the program is really driving vaccination of all dogs and making sure that all dogs within that 10-kilometer radius are vaccinated. We've identified hotspots using spatial modeling, very similar to what we did in Brisbane. And we're now focusing more local studies here to the south of China in the province of Guangxi, where most of the pediatric cases are still happening. So this is all being driven because for rabies, we have a target, a WHO target for rabies elimination by 2030, dog-mediated rabies. And so there's a big push towards elimination in these hotspots, particularly the pediatric cases. So we've been doing some work that involves desexing animals in those hotspot locations in Guangxi, health education in schools that involve messages, videos, and also leaflets to the students. And I'm going to show you some results of that. So we started in a small community which is highly incident. So the incidence is very close to 125 per 100,000 of population. It's very, very high. And most of the cases occur in children, in school-aged children. So we started with an interventional trial with mobile phones to the community, to the parents, mobile phone messages, with a set of 10 messages over a period of 6 months with some health education embedded. And then in the schools, we provided information sessions and posters and designed a video that the children use as part of their curriculum in year 1 and in year 3. We've published this work back in 2016, and the impact was quite striking. We really reduced the knowledge and attitudes of practices of children increased significantly. And what we found is that in communities that received both the messages, the SMS messages and the health information in schools, there was a very stark decrease in dog bites and also an increase in the knowledge, attitudes and practices of children towards dogs compared to the message alone or the video alone. Now, just to conclude, some key findings from the context in Brisbane. Dog bites, they do impart a significant public health burden. We see that there's a 15-fold increase. Well, the pediatric population has a 15-fold more likely to suffer bites to the head, face, and neck. That is consistent to a number of studies elsewhere. The effect of dog size on the risk of human presentation differs between the 3 clinical outcomes. So we see that children tend to be bitten by larger dogs compared to small dogs, but the head injuries, they tend to be inflicted by smaller dogs. Clusters of pediatric cases tend to be larger in size, about 3 kilometers, and but the neck injuries and the representations tend to be much smaller in circumscribed locations. So the maps we've generated can really drive interventions locally just by focusing on those communities that showed a higher risk for these 3 outcomes. So targeting campaigns 2 to 3 months prior to annual seasonal peak in November, January. These campaigns could be health education going through schools in Brisbane, showing videos. We would be very keen for that to happen. These include health promotion, health education towards dog ownership in dog parks. That could be a particular site that could be targeted, given that our analysis is showing some of the pediatric cases as well, that the locations were very close to dog parks and also schools, and target areas, campaigns where this socioeconomic factor of disadvantage is highest. Locations particularly in the Logan region and parts of the Redlands. Given that socioeconomic status has been a strong risk factor for particularly the head injuries. Hospital records to provide a better clinical assessment. And I think Brad mentioned this. We really struggle to have a really decent working database. There was a lot of missing data in the clinical notes of doctors. No fault of them. But it can be improved so that we understand a little bit better about the offenders and the circumstances around the attack. That will give us a little bit more insight in terms of interventions that could be placed locally. And that's really it for me, just some acknowledgements on the participating Metro South Hospital administrations, and then for the studies in China, our collaborators over there, and our staff and students at the Spatial Epi Lab have been really fantastic at putting all of this together so far. We would like to take some questions from the floor now. I think we still have another 10 minutes or 5 minutes. Sorry for going a bit over time.
No, absolutely. That was a fascinating presentation. Thank you. And such relevant content for the group that you're speaking with today. So there are a number of questions. One is around the reporting aspect of things. So are dog attacks escalating in numbers, or is reporting getting better, or are councils becoming more risk averse or aware? Do you have thoughts on that?
I guess it's hard to know. I'm the epidemiologist behind the data, but looking at the graph, and if we adjust by the population at risk, right? The population has also been growing. Dog ownership has been growing. So these are important factors to take into consideration when analyzing these trends. But adjusting for that, you do see an increased number of admissions, right? ED admissions. Now, the reasons for that, why that is happening, is really unknown. One factor may be that individuals are perhaps having different behaviors towards dog ownership. Individuals that are new in having a dog, they're not quite aware of the risk associated to their health of having that dog, and so that could be an option there. I don't know, Brad, what do you think about? Do you see an increase in your normal clinic?
I think the numbers themselves have been, at least in our study, we saw that over the past few years, they're sort of relatively stable. I guess the concern is that ED as a whole is getting busier and busier and busier. And these dog bite presentations are quite complex to manage. They're different from just usual, cuts, abrasions and stuff, in terms of, they happen in areas which we don't like them to happen. So like, your head and face and your hands. So I guess our concern is that these bites take a long time to sort out, and anything we can do to try and reduce them coming to ED is our priority, to try and relieve the load on the rest of the workload. So I think although our study showed that the numbers over the past 4 or 5 years have been fairly static, they're certainly not helping towards our current sort of ED overcrowding crisis. Yeah.
Absolutely. And just a comment from me, when you were talking about the breeds identified in past research in dog bite incidents, there's been some recent research coming out of the States where shelter staff were interviewed, showed photos of various dogs, and were asked to guess what that dog breed was. And a lot of them were, pretty much all of them were crossbreeds. And those that were identified as pit bull, a large proportion of them had absolutely no pit bull in them whatsoever. It was just that the morphology is something that we name a pit bull type of dog. So we definitely need to do more work around that. And now that we have some really good DNA testing options there to look at the genes of the dogs, that's definitely something we need to look at, because more and more we're realizing that breed identification on the part of the professionals in the field, in the animal fields, isn't there. And so it can't possibly be there in the public or, in any other field. So that's just to put that out there. We've got another question here around the location that these dog bites occurred in. Do we know the numbers that are occurring in public places, in particularly fenced off-leash areas at dog parks, or versus off-leash areas or unfenced versus on-leash areas? So was there anything that came out in your research around that?
And unfortunately, we can't go to that granularity. The missingness on the clinical notes is significant. But with what we've been able to ascertain, so there's a number of sites and settings, and so we classified indoor, outdoor, public area, right? So the numbers are already so small in the clinical records that then you can't really look for a specific effect size of dog park versus, say, home. We would really need a larger, more, I guess, systematic data collection from our ED doctors to have that understanding. But again, yeah, so the only thing we could do is really outdoors, home, public, and not public areas. So you couldn't go to that granularity, unfortunately.
Yeah, absolutely. And look, this is maybe an area where groups like the Australian Institute of Animal Management, we may be able to help you further down the track if you've got further research projects in mind. But future questions. We've got another question here from local government. Has there been a noticeable increase in dog bites or attacks during COVID, where there was a significant increase in uptake of fostering, and I would also add adopting dogs, since March last year?
So that's a great question, which leads to a very pertinent research project. What I can say is that we're working with our SPCA in terms of the rehoming aspects and also the adoption. So both goes both ways. We're seeing interesting patterns that then can influence a number of things in the community, right? So what can be done is again looking back to the clinical records for the period of 2017 onwards and make that comparison. Brad and I, we are extending the present study. We are requesting an extension to our current ethics agreement to have those data to answer questions such as that one. Yeah.
Fantastic.
But yeah, it's possible, totally possible to do and triangulate with our SPCA data on the adoption and rehoming. Yeah.
Well, that sounds exciting. So we've got some other questions that have appeared in the chat around, I think, local government being able to obtain evidence from hospitals being problematic. What is the, I guess, correct route there for local government teams to take if they've had an incident reported to them and it has been admitted to hospital, or the human was admitted to hospital. And also, I guess, more generally around the reporting mechanisms from human medical health facilities back to local government.
Brad, I think this is for you.
So again, reporting, there's no mandatory reporting criteria for medical staff or any health staff to the council. So there's actually not very much guidance in the current guidelines. The Children's Health Queensland guidelines have a tiny section on reporting. It's about 2 sentences long, and basically says that medical staff can feel free to report the incident to the council if they choose to, but there's no obligation to. So it's not something that is routinely done. And I guess if there's a patient who got admitted with a significant injury, then we'd have to get consent from the patient to forward that on to the council regarding details of that attack. But so it's not routinely done, no, in ED, no.
Yeah, and I guess it's a big gap in the whole picture, isn't it? So, and another question here from local government.
Just on that, Nell, just
yes,
quickly, it would be worth really triangulate the data we have with the declarations that council have for dangerous and the dangerous declarations, because that triangulation will give you the amount of underreporting that is happening. So you've got, on the one hand, individuals showing up in the hospitals, but then on the other hand, you have these declarations being given to individuals by councils, right? So if we can triangulate that information with our council counterparts, we would be able to understand where these geographically, where the mismatch is happening more often. Yep.
Yeah, no, that's a good point. And just another comment from local government, often dog bites occur in the owner's home and are not reported to councils. So in Victoria, it isn't possible to take actions for unreported attacks, and we often don't get access to data for unreported dog attacks. How can we get this data?
Citizen science. What we can do is really work with the ED departments, and that's as I mentioned, the tip of the iceberg. The reporting pyramid becomes very steep and depends on a number of factors. Severity is perhaps the most important one, and who's been bitten. If it's a child, you're more likely to take the child to hospital, isn't it? So there's a number of nuances and confounders there for the reporting pyramid. The only way to overcome that is that we have like a magpie alert system where citizens that are bitten, just place their, well, I've been bitten by my dog, but that is very unlikely that it will happen if it's a known dog, well, your own dog, but it can happen if it's another person's dog, but then you're also more likely to seek assistance. Yes, so yeah, I think it can help citizen science, but not sure how effective it would be to uncover that bottom part of the pyramid.
It's a really difficult one. And we've got another comment here in regards to the declarations for the dogs that have had a dog bite. The declarations relate to animals as well as humans. So we need to distinguish whether it was a human bite or another species of animal bite or another dog bite.
Yep.
All right. Well, I think that just about covers all of our questions. As I said, we will have this presentation on our website in the next day or two, and it will include the questions and question time. It's been a really fantastic session. Very, very happy that we've made contact with you guys, and thank you so much for doing this work. Thank you everybody for attending today. Stay tuned to our social media pages and e-news for announcements about future webinars in this series, and feel free to send us through suggestions for future topics or speakers or anything like that. We'd love to hear what you're wanting to see. Take care everybody, and thank you again for your time. Have a wonderful afternoon.
Thanks for having us.
Thank you.
Goodbye, Brad.